Good afternoon. Good afternoon, everyone. Apologies that the voiceover just interrupted. It's 1 o'clock and it's time to begin. Welcome to this Mind Out webinar on LGBTIQ plus mental health and suicidality, the state or territory of affairs. My name's Terence Humphreys and my pronouns are he and him. I'm the Mental Health and Suicide Prevention Director here at LGBTIQ plus Health Australia. And joining me this afternoon is also my colleague Liz. So they are off screen, but you may have seen Liz on other webinars. We work together on the Incredible Mind Out program. Before we begin, I'd like to start by acknowledging the traditional custodians of country throughout Australia and their diversities, histories, knowledge, and continuing connection to land, water, and community. I'd like to pay our collective respects to elders, past and present, and extend that respect to any Aboriginal or Torres Strait Islander people joining us today. I'd also particularly like to pay my respects to elders of the Gadigal people of the Eora Nation from where I'm joining. I'd welcome you to use the chat function if you like to share where you're joining from throughout our country today. At this point, I'd also like to acknowledge people with living experience of mental health or suicide distress, as well as their carers and families, and note the continued role they play in the reform of the mental health system. Just a little bit of housewarming before we get started. Our webinar today is being recorded and will be made available on the LHA, the LGBTIQ Health Australia website, LHA. So if you miss any information, you'll be able to go back and listen. That'll be available in a little while. For questions, we invite you to use the Q&A function, which you should be able to find at the bottom of the screen that you're viewing from today. And we will aim to get through as many questions as we can in the allocated time. We also have some from before the session that people have sent in, so thank you for those. We'll be sitting with some fairly heavy content around suicidal distress and involuntary admissions and treatments today. So this is a timely reminder now that if anything in today's webinar brings up any issues for you, that support is available. You can contact QLife, which provides Australia-wide anonymous support for the LGBTIQ plus communities. QLife services are free and can be accessed via qlife.org.au. And I might ask that Liz pops that into the chat for you so that you can copy and paste that should you choose to use that. I will also note that depending where you are in Australia, the service might not be open at the end of this webinar. Services are between 3 p.m. and midnight wherever you are. But there are also other helplines available, of course, which we would encourage you to reach out to if QLife's not available. But joining us this afternoon, we're thrilled to have Jordan Hinton, whose pronouns are he, him. Jordan is a research officer at the Australian Research Centre in Sex, Health and Society, or ARCHES as it's informally known, and La Trobe University. Jordan has a primary interest in LGBTIQ plus health and well-being, stemming from a background in social psychology. Jordan's research and general interests center around understanding the mechanisms through which experiences of prejudice and discrimination impact the health, lives, and interpersonal environments of LGBTIQ plus community members. Jordan also has adjacent and overlapping research interests pertaining to the following: social identity and group processes, community connectedness and resilience, prejudice and discrimination, sexual behaviors and sexual well-being, relationship dynamics, quantitative methodologies, and advanced analytic designs, such as experience sampling designs. We were to have a second speaker, Jordan's colleague Nat Amos, but unfortunately they are unwell, won't be joining us. But uh, please join me in welcoming Jordan to talk about the state or territory of affairs. Over to you, Jordan.
Thanks, Terence and Liz, for having me here. It's really great to have this space to be able to sort of talk about and disseminate this research that we've been doing here at Archers. As Terence mentioned, my name is Jordan Hinton. I use he, him pronouns, and I'm presenting on behalf of myself and Nat today, who unfortunately is just a bit unwell today, so I'll be talking sort of on her behalf as well. But we do have our email addresses there as well if anyone is interested or had any questions after the session as well. I'd also like to acknowledge that I'm joining from Wurundjeri land down here in Naarm in Melbourne, and also extend my respects to elders past and present as well. So I'll kick off and get started with essentially what I'll be talking about today. I'd like to start off with just a few more acknowledgements, just to sort of center or provide a foundation on what I'll be talking about today. So in brief, I'll be talking about the dissemination of data from 3 large data files that we have here at Archers. The first one is the Private Lives data file. And this was funded by the Victorian Department of Health and Human Services, as well as the Department of Premier and Cabinet, with numerous advice and support from a variety of community advisory boards and gender reference groups and various stakeholders and internal study team members. I'll also be talking about the Writing Themselves in 4 data project, which was generously funded by the Victorian Department of Premier and Cabinet, the New South Wales Department of Health, the Office of LGBTIQ+ Affairs in the Australian Capital Territory, Shine SA, and with support from the Office of the Chief Psychiatrist in South Australia. Again, as well as a variety of support and advice from various community boards and stakeholders. And finally, the Pride and Pandemic Survey, which I've listed here. I'm not talking all that much about in today's talk, but it does form part of the state reports that we've developed. Again, this was funded by the National Mental Health Commission and through partnership between Archers and LHA, and as well as several advice and community support groups there as well. In addition, I'd like to acknowledge that the secondary analyses that I'm presenting from today were made possible by generous funding from the Commonwealth Department of Health and Aged Care through a partnership between Archers and LHA as well. So to kick us off, just a little bit about the key surveys that I'll be talking about today. So as I've sort of briefly mentioned, the first one I'm talking about today is data derived from the Private Lives study. So this was data from around 6,481 LGBTIQ adults aged 18 plus in Australia. Data were collected from July to October in 2019, so late 2019, just before the pandemic kind of started. And it was available online or paper copies upon request. The Writing Themselves in survey was very much the same in terms of the content that we captured. We got a very similar sample size, so just over 6,400 folks. However, this one was targeting LGBTQA plus young people aged 14 to 21. Again, this was data collected in the same period of time, so sort of late 2019 through online methods as well. And finally, the Pride and Pandemic Survey was a smaller sample size, but still quite large nonetheless, with just over 3,000 LGBTQ plus adults aged 18 over. And this was collected from late 2021 into early 2022. So these are the sort of the broad reports, which can all be found on our website and the various publications that have derived from them over the years. These are the reports that the data that I'll be talking about today are all derived from. So in short, essentially, we looked at this data and wanted to sort of assess rates of suicidality and rates of mental ill health among the queer population, but within each state and territory within Australia. So through the analyses of this, we were able to generate these 8 distinct state by state or state and territory based reports. So these are just briefing reports that we've developed, and I'll share some links at the end as well about how you can access these and where you can find them. But essentially, these just detail very similar findings across each one of them that reports on rates of suicidality and mental ill health, as well as a variety of risk and protective factors that were associated with suicidality risk, but importantly within each state and territory. So this is what I'll be talking about today. So just a really brief sort of recap. Essentially, I've just sort of talked a little bit about this already, but essentially these reports use data from all three of our available surveys, with primarily focusing on the first two, so private lives 3 and writing themselves in 4, just because the sample sizes were a little bit larger, with extra nuances or more fine sort of fine-grained approaches and analyses coming from the private pandemic survey as well. So as I mentioned, each of these reports provide general rates of suicidality across each state and territory within Australia for these communities, as well as provides insights on various risk and protective factors that are related to suicidality. Throughout each report, we also provide a state-by-state kind of comparison. And lastly, and perhaps quite crucially, at the end of each report, we also provide and highlight areas of improvement for policy and programming contexts, but importantly within the state and territory level. So we look at primary health networks, for instance, and we look at sort of their websites and what's available, and just to provide a bit of an evaluation on how this can be improved at the state and territory level. To give you a bit of an insight on each report, so with our sampling strategy, we didn't have even numbers of participants across each report. So what we do have is displayed here. As you can see, the majority from each of our key surveys, the majority of participants were residing in Victoria or New South Wales as the sort of the key, or I guess larger sample sizes across each of these reports. In terms of, after New South Wales, we also had the majority of folks residing in Queensland, followed by WA, South Australia. And then on the sort of lower end, we also had around sort of smaller proportions of participants residing in ACT, Tasmania, and then importantly, there was only a few or a handful of folks who we sampled from Northern Territory. So I'm just sort of stating this as just a bit of a caveat, I guess, that each report does come with these certain limitations in terms of what we could actually do given the sample size and things like that. So especially, say, Tasmania and Northern Territory, some of the results might be a bit less confident, I guess, in terms of their findings and their patterns, just because of how small the samples were. And definitely an area for future improvement as well. So just to kick us off, obviously what I'm talking about today is can be quite hard to swallow or hard to sort of look at as well. So just a general kind of overview, I guess, here about the suicidality rates at the state and territory level. So I've just sort of popped them in this graph here just to give you a general overview of what they kind of look like. Again, within each state and territory. So the blue bars here, the ones on the left, represent suicidal ideation in lifetime. Followed by these purple bars here, which represent suicidal ideation recently. So this was measured in the last 12 months. And then the red bars here, the dark red, we have suicide attempts in lifetime, followed by suicide attempts in the last 12 months, so recently. So taking a step back and looking at this graph, it's quite evident that these rates are extraordinarily high across the board. So as you can see, up to around 70 to 80% of folks in pretty much all state and territory have experienced some sort of suicidal ideation in their lifetime. Recent levels were still extraordinarily high, and same with suicide attempts as well. This was just in the case for private lives 3. So this is just the data from LGBTQ plus adults. But as you can see here from writing themselves in 4 on this next graph, you can see that it's either higher or very similar rates for queer young people as well across states and territories. So as you can see, it's up to say 85, almost 90% across most of these instances within state and territories for young people. This might not come as all that much of a surprise. I guess we do know that the queer community experience high levels of suicidality in comparison to general population. But this next graph basically just goes to show how extraordinarily high these are, and especially within state and territories. So this is just a graph here to exemplify recent suicidal ideation. This is just from the adults sample in Private Lives 3. So as you can see here, in comparison to the general population, which was around 3.3% according to the ABS, and their most recent data in 2022, we can see that in comparison to that 3%, LGBTQ plus adults have experienced recent suicidal ideation extraordinarily much higher in comparison to that. So ranging here around the 40 to 50% kind of level. You can see here that there is some sort of fluctuations, I guess, between state and territory. But the key sort of takeaway message here is that it is still extraordinarily high across the board. This next example is to sort of show this a bit further as well. So this is just in terms of recent suicidal attempts. So it's the same kind of story that we're seeing here, that in comparison to general population estimates, which are estimated to be around 0.3% of the population, those in the queer community across states and territories experience extraordinarily higher rates of recent suicide attempts. Now, as a bit of a caveat, it looks like there are some sort of stark differences here between states and territories, but it is important to note that this is sort of quite zoomed in the sense that these rates only vary between, say, 5 and 9%, which is still quite extraordinarily different. But the main thing, I guess, to take away here is that across state and territories, they are still extraordinarily much higher than general community members. So looking at this data, we also wanted to explore this a little bit further at various intersections within state and territories as well. So we also explored how these rates of suicidality and mental ill health and various other factors, which are all presented in the reports, how they might differ, for instance, among those with trans and gender diverse identities compared to those who were cisgender across adults and young people. And essentially what we found is that across the board, trans and gender diverse adults and young people experience poorer suicidality and mental ill health outcomes compared to their cisgender counterparts. We also looked at this across LGBTQA plus adults and young people with disabilities, and we found that suicidality was extraordinarily higher among those with disabilities. And we also looked at this as a factor of ethnicity groups and looked at, say, multicultural versus Anglo-Celtic young people and adults to explore those differences. In terms of that one, there are some differences that emerge in that data, but we do have a new report coming out soon in the next couple of months that looks at this with a much more fine-grained approach to provide better nuances. So definitely watch this space and sort of stay tuned for that one as well. I'll talk a little bit about that at the end as well. Throughout each report, one of the key things that we explored were risk factors. So generally, based on a variety of literature and sort of community understanding, we know that there are a variety of risk factors out there in terms of things like discrimination and harassment experiences. So for instance, having experienced verbal, physical, or sexual-based harassment, intimate partner violence, for instance, or family violence, as well as lifetime homelessness experiences. So of course, these aren't the only risk factors out there. These are just sort of one of the more key ones, I guess, that we focused on for these reports. And essentially what we found was that these risk factors were associated with an increased risk of suicidality and an increased risk of mental ill health across each state and territory. So these were risk factors across the board and quite strong risk factors that we found here. In terms of protective factors, these were some of the key ones that we explored within the reports, and there were a few, I guess, more slight differences between state and territories as well. So some protective factors against mental ill health, or those that decreased the risk of suicide or suicidality, were things like feeling accepted and or receiving support from family members was a really strong and key protective factor that we found here. This was evident across all states and territories, with the exception of Northern Territory, just because the sample size was too small. So we weren't able to actually run those analyses. but within all states and territories aside from Northern Territory, this was a key protective factor. We also found that greater levels of belonging and connection towards the broader LGBTQIA plus community in Australia was also protective against mental ill health and suicidality. So these were associated with a decreased risk of suicidality and mental ill health. This was broadly found across New South Wales, Tasmania, Victoria, and WA. Even though this result wasn't found, I guess, and I'm talking here just statistically, across places like Queensland or South Australia, for instance, the rates in which people were connecting with community were moderate to still high. So we do know that this is a key protective factor in general. And lastly, we also found in terms of young people specifically that affirming school environments were quite protective against their mental health or suicidality outcomes. This was particularly found in Tasmania. So I'll show you a few more graphs here just to sort of ground this context, but this one here is just in terms of community connectedness. So we have two kind of metrics here of connectedness. So the blue bars here, or the ones on the left, general sense of belonging to the broader LGBTQA plus community in Australia. And on the right-hand side here, these green or teal kind of bars were around positive participation. So participating in the queer community is a positive thing for me, which was what the items were that participants were asked. So as you can see here that across the board, again, with the exception of Northern Territory, just because the sample was too low, across the board here, rates were at least, say, 50%. So the majority of the community felt connected to the broader community. However, it could certainly be much higher as well. So there certainly are instances where we need to improve community connectedness and enhance this to better support those who need it, or better sort of help buffer against the poorer effects of mental ill health and suicidality. So what I'm presenting now is just essentially just some snapshots that I've taken from within each report. I'm only doing this across 6 states, so I'm not looking at the ones from Tasmania or Northern Territory just because the sample sizes were a bit too small. But just to give you some insights on how some states might differ compared to the broader context in Australia. So I'll start off with some positives. So essentially, as we can see here from Australian Capital Territory, young people from ACT were more likely to feel connected to their school environments. In terms of New South Wales, for adults, adults were less likely to experience suicide-related concerns. And in terms of young people in New South Wales, they were less likely to have ever experienced homelessness. So we can see here that there are sort of perhaps a state-by-state benefits in some states, or hindrances, I guess, in other states that can sort of help exacerbate this. In terms of the negatives, we find that among adults in ACT, they were more likely to experience lifetime suicidal ideation. Among those in New South Wales, they were less likely to have access to LGBTQA plus specific mental health services. In Queensland, unfortunately, there were only negatives that we could find in terms of state-by-state comparisons. Again, this is just from our data set and at a very broad sort of analytic level. But we found here among adult Queensland residents, they were more likely to experience suicide-related concerns. They were less likely to feel connected to the broader queer community. And among young people in Queensland, they were more likely to have ever experienced homelessness, and less connected, less close, and less happy to be within their schooling environments, which we know is a key sort of affirming thing for young people growing up as well. In terms of Victoria, WA, and South Australia, there were a few positives and a few negatives across the board as well. In Victoria, we mostly found some positive state-by-state comparisons. So we found in Victoria, adults were less likely to experience suicide-related concerns broadly. We found that they were also more connected to the LGBTQ plus community in Australia. And among young people in Victoria, we found that they were also more likely to feel connected towards their school environments. So they were happier to be in their school, they felt more affirmed to be in their school, and they felt more connected to be in their schooling environments. In WA, we also find that young people were also less likely to have higher levels of psychological distress, which is an important finding there as well. Unfortunately, we also find some, I guess, more on the negative end state-by-state comparisons here as well. So for WA, we found that queer adults were less likely to have access to queer-specific mental health services. We also find they were less likely to feel connected to the broader Australian LGBTQA plus community. And also in South Australia, where the sample sizes were a little bit smaller, we also found that adults were less likely to feel connected to the broader community, and young people were more likely to experience moderate to high or moderate to severe levels of generalized anxiety. So as you can see, there is a bit of a state-by-state kind of effect here, where some states might perhaps imbue more affirming environments or have perhaps better policies in place and things like that. So that's essentially why we wanted to develop these reports, is just to sort of understand what is the state of play, essentially. Within each report as well, we also, instead of just risk and protective factors, we also explore various healthcare service access types of factors, just to understand what are sort of these rates within each state and territory. So we explored a few things like if young people and adults had regular GP, if they had a regular healthcare service that they attended, or in future, which types of services they might like to attend, or if they had ever attended, say, a suicide-specific service. All of these are detailed more explicitly, I guess, within each report. But just as a general overview for this presentation, what we found that across most states and territories, most participants have accessed some form of support for their mental health. And these were mostly accessed in terms of mainstream services. So not queer-specific services or anything like that. We also found that slightly less than half had reported feeling accepted by their healthcare clinician. So we know that healthcare acceptance is a huge barrier for continued support and more affirming support. So yeah, it was important to sort of document that one here as well. And we also found that most participants in future would prefer to see an LGBTQA plus inclusive service for their mental health. So we've got some of those stats here as well. So this is the felt acceptance in healthcare. Again, this is by state and territory. You can probably see here that Northern Territory stands out a little bit more, but again, it's important to note that this was only a really small sample. So across the majority of states, you can see here that just under half participants felt accepted. So there is obviously a long way to go. Or in other words, this is kind of like saying that around 60% of them did not feel accepted in their healthcare setting. So there's definitely more ways to go in terms of how to promote acceptance. And lastly, this is just the sort of outline of mental health service preferences in future by state and territory. So we asked adults if they had no preference for a future service, if they preferred to see an LGBTQA plus inclusive service or an LGBTQA plus specific service for their mental health in future. So the majority, or the most prominent result here, I guess, are these purple bars. So the majority of folks wish to saw an inclusive service, followed by they either had no preference or there was a need to see a specific service in future. But it is quite telling, I guess, to say that even at the inclusive service level, this is sort of what's needed and might be driven by what we just saw in terms of healthcare acceptance as well. So I'll just sum up now. Essentially, as we can see here, these reports have highlighted high rates of suicidality across all states and territories within Australia. There were some state-by-state kind of differences, but at the broader sort of level, these rates were relatively consistent and still extraordinarily high across states and territories. The primary risk factors here that we found were including harassment and violence experiences, as well as experiencing homelessness. And primary protective factors, I guess, that we found across each state and territory were factors like feeling accepted by family members, as well as greater levels of community connectedness or school connectedness. And again, as noted within each report, it is quite a detailed, I guess, and quite specific to each state and territory in terms of the recommendations at the public health network, or sorry, primary health network level as well. Just a bit of a teaser, I guess, of what's upcoming from us. So those 8 state-by-state reports are already available on our website and the LHA website. But we do have some more coming up. One of them is just sort of, this is just a sample page, I guess, from what is coming up. We are organizing to release a snapshot document, which instead of having to read, say, that 20-page state-by-state report, you can just read essentially just this 1 to 2 page report that highlights the key stats, just for sort of an easier access and just something that is easier to flick through and sort of compare state by state. So this is just an example of what the Queensland page might look like. We're still in sort of development of this, so definitely stay tuned. So this one is coming soon. We also have a few upcoming reports coming up in June, so just a few months away. These are definitely on their way and providing some really interesting kind of insights there as well. But we have 4 new reports coming up just to provide a better understanding of suicidality rates, but at the intersections of various systems, I guess. So at the intersections of LGBTQ plus identity, and also the first report looks at race and ethnicity. The next report is looking at age, so particularly among older LGBTQA plus adults. Then we're going to be looking a little bit more in depth at regional and rural locations and remote communities. And finally, something that we haven't done all that much about yet is socioeconomic status and income. So we know that, for instance, there are various barriers in terms of healthcare acceptance and need for healthcare. But looking into the affordability and the actual accessibility of healthcare as well is very much needed. And finally, I'll just briefly talk about this. I think Nat was going to talk about this a bit more instead of me today. But we would like to also sort of point towards some various other more recent reports that we've done through Arches. So these include, we have a series of Aboriginal and Torres Strait Islander fact sheets that we've released on our website as well, which document various rates of suicidality and mental ill health concerns, as well as various protective factors and risk factors there as well, specific to Aboriginal and Torres Strait Islander LGBTQA plus communities in Australia. In addition, we also have a variety of trans and gender diverse publications and broadsheets which are coming soon. So for instance, there's one that I'm leading at the moment, which is currently under review, looking at trans and gender diverse young people's experiences of suicide and what that means and how that's related to various protective and risk factors. But there are also a variety of other publications that are upcoming, looking at gender affirmation and support for gender affirmation and mental health outcomes, gender euphoria and well-being, as well as affirming education and workplace settings as well. So I'll leave it there, but yeah, I guess I just want to say thank you again for having me. Terence and I will do a Q&A session now, but I've got a QR code here and these slides will be circulated around after the meeting if you want to check out the reports. And of course, my email's there and Nat's email's there if you had any questions as well.
Thank you so much, Jordan. And thank you, everyone, as you're putting your questions in. I fear there may be too many to answer in the 25 minutes or so that we have left, but we will give it a good try. It was really interesting hearing how those different jurisdictions have different priorities and challenges. I'm sure it's been very insightful. We've already had a few interesting comments in the chat there. One of the participants said that for Queensland, there were only negatives, not positives, but I feel that might not be true. Jordan, is that right? There were positives for Queensland as well. That might be
Sorry,
important
yeah,
right now.
there definitely was. So those state-by-state comparisons were just in sort of more the broader context from comparing states, but within Queensland, there definitely were a variety of protective factors and positives as well.
Wonderful. Yeah. So perhaps, I'm sorry, I didn't take note of that participant's name, but thank you for raising that question. But maybe check out the Queensland report and it will give a bit more information about those strengths there. One of the other questions that someone asked here was the percentage of participants who were intersex across the three surveys. Did you want to speak to that, Jordan?
Yeah, absolutely. Look, it's a very, very good question. We've throughout our reports, we've unfortunately only had quite a small sample of intersex participants and participants with variations in their sex characteristics. With each report does sort of document that unfortunately, because the sample sizes were so small, we couldn't actually analyze the data in a way that makes it still unidentifiable, I guess, in a way. So unfortunately, we couldn't actually analyze that data, which is, I guess, just a huge kind of caveat for private labs and writing themselves in general. But it's definitely something that we're geared up towards improving, especially with these new reports upcoming as well.
Fantastic, thank you. Are there any statistics around mental health and suicidality for adoptees, in particular adolescents and children within Australia?
Yeah, that's a really interesting question. From memory, I don't believe we asked about those questions in our key surveys. So I don't think I know any stats off the top of my head, I'm sorry. But yeah, that would be definitely something interesting to look at in the future. Yeah, definitely. Absolutely.
Thank you. This question was about how we address the social determinants of distress, suicidal ideation among the queer community, and I guess LGBTIQ plus, sorry, LGBTQ plus communities. Were there things in the positives from the report that kind of point to how different areas should be looking to address those?
Yeah, I guess look, one of like from what we know, one of the strongest determinants of buffering against negative health outcomes were just general senses of community connection, but also like school-based connection, especially for young people, and just general sort of affirming environments. So like greater family support, greater friendship support, and things like that. It's sort of this age-old question of how do we actually bolster these community support networks, and it's definitely, yeah, it definitely can be tricky, but I feel like yeah, just ensuring, for instance, like adequate training for healthcare clinicians, adequate policies and programming can actually really help strengthen these affirming practices.
That's great to hear. The next question is about data on people with disability who also identify as LGBTIQA plus. Was that a factor that was explored in the three surveys, Jordan?
Yeah, absolutely. So each report or each of these state reports report on various intersections in terms of disability as well, but not to the quite granular, I guess, extent of the data. But the reason why is because Arches has already released a report on LGBTQ plus people with disability, which we can find on our Arches website as well. I think I might not be able to link to it right here, but yeah, there's definitely a report on there that looking at the queer community and those with disability and various mental health factors as well.
Fantastic, thank you. This is a good one. Were there any surprises for you and the team in terms of differences between different states and territories? So any surprises?
Yeah, I mean, look, to me, I guess the surprise was that a lot of them were quite similar. So like it was almost a surprise that we didn't see more differences. One of the most, or perhaps surprising finding I found was that in Tasmania had the strongest level of school affirming environments for queer people, for queer young people. I'm not sure why it's surprising to me. I guess I don't actually know all that much about Tasmania, but we did talk about our colleague who works in Tasmania. She works at Arches but lives in Tasmania, who helped us write that report as well. And looking at the specific programming and policy context for Tasmania in particular was quite interesting. But yeah, it was a really nice, a nice almost affirmative finding as well, because we find so much dark, heavy stuff in these reports that
Yeah.
it is quite nice to see the light a little bit.
Yes, completely. I think we're all in agreement with that.
Yes, definitely
Uh,
shout out to
what
Dr. Ruby. I can see that in the chat.
Yes, hi, Dr. Ruby. What's known about the intersection between mental health and the law for LGBTQIA people, is the question. So the intersection
Mm.
between mental health and the law. I'm not sure if that was something that the surveys explored, Jordan.
Yeah, I mean these reports didn't really explore that. Off the top of my head, it's not really my area of expertise, I must say, but we do work with some colleagues that look at that have sort of more of a law background and are looking at things like sexual violence perpetration, for instance, as a key sort of element of their work. And there's some great research coming out at the moment from them. So definitely stay tuned. I'm not sure that I can answer that specifically without much of a knowledge base under my belt, unfortunately. But yeah, it's definitely something that is worth exploring as well.
Yeah, I'm not aware of any Australian studies that
Yeah.
are in depth, but certainly there are some studies from overseas. And of
Yes.
course, the news isn't always very good in those studies, but definitely an area to explore further,
Absolutely.
particularly with the link with mental health. What research and data information can you share? Oh, sorry, beg your pardon. I've already done that one. What services would you recommend for families, carers who are supporting a young person who identifies as LGBTIQA plus? And I'll let you off the hook with this one, Jordan, as this isn't your area of expertise. But certainly from LHA's perspective, we would refer people to our member organisations, and in particular 2010 here in New South Wales, Transcend as well, which is a national service. And some of the other services have projects and bits and pieces. So I'd encourage people to have a look at the member page of the LHA website, or simply to Google it. And of course, remembering Q Life as well as a really important support service there.
I think that's something really important to acknowledge as well, is that like a lot of this stuff, this research, a lot of this research, I guess, that we conduct does, and rightfully so, have a very central component on the person with lived experience of suicidality themselves. But we often, as a first point of call, which is absolutely needed, but there is often the need to explore how it affects close others, so families and carers, but also like I was talking to my colleague the other day, and there's just not enough research, especially in Australia, looking at, for instance, like parents of trans and gender diverse kids or parents with queer kids and understanding their experiences. And I think this sort of notion, I guess, of allyship and affirming sort of behaviors from people outside of the queer community is equally important as well in terms of ensuring of like affirmative and flourishing environments for queer people.
Thank you very much. Are there estimates of, oh, sorry, I can't read I can't read the whole question on my document. It's obscured. How do I get that back? I'm going to have to let that one go. What key preliminary findings can you tease about the differences in suicidality and healthcare accessed, that's accessed based on race and ethnicity, if anything, from those surveys?
Yeah, so the upcoming report we have looking at race and ethnicity in a much more fine-grained context will definitely speak to that. So we've only sort of just started diving into the data, but essentially what we're finding is that there are uh, various sort of intersections, I guess, of the queer community and those with more marginalized racial and ethnicity experiences that do have poorer healthcare experiences as well. So we definitely look at that in a much more closer depth. So yeah, definitely stay tuned for that.
Excellent. We'll all check that out when that's available. The next question is around how maybe the data or the experiences of people have changed since COVID. And is new data being collected for comparison? And do we expect it to be even worse now? It's no laughing matter, but it's yeah, it
Yeah.
speaks for itself, right?
Yeah, I mean, look, obviously this data that I spoke about today was mostly from 2019. But we do with the new National Action Plan funding, we'll be launching new surveys. So the new sort of, I guess, iterations. I can't remember exactly when that might be, either later this year or early next. But yeah, we're definitely very, very excited to see what the data is saying, because we've only really had these estimates from the past, I guess, pre-COVID kind of days. So yeah, we are very much looking forward to seeing what the data has to say. I'm hopeful that things are getting better. It's hard to say whether things are getting worse or better, but I'm hopeful that things are getting better. But I can certainly see that there is a need for much improvement around everywhere as well.
Absolutely, and there are lots of services available to support people around the country. You know, and again, just to plug the member section of the LHA website, where you can find information on both community LGBTIQ plus community controlled organizations, as well as more mainstream organizations that have projects that support our communities. An interesting question. What were particular or established measures used for the data collection? Someone would be keen to know which ones. And again, I'm sorry I didn't keep track of who asked which question. Yeah, what do you have to say about
Yeah,
particular established measures?
this is right up my alley. I have a background, I guess, in quantitative statistics, so which might bore a lot of you, but I love it. But yes, so certainly because of the scope of the surveys and because the surveys are quite large, we do ask a lot of content in them. We develop our items and our surveys from existing validated measures, but usually to a smaller degree. So instead of, for instance, having a 17-item discrimination measure that's been validated and standardized, we would choose perhaps the most strongly relevant items for those. And then essentially, we also evaluate these items in terms of their face validity and their content with queer community experts as well. So queer advisory groups as well, just to make sure that the items are appropriate and understandable, especially for our writing themselves in force survey. So are the items, for instance, interpretable and understandable and accessible for people as young as 14 as well. But yes, in short, yes.
That's awesome. I hope that answer provided some insight for the person that asked that. Any observations about the recent federal government inquiry related to suicide prevention, including LGBTIQA+ people?
I mean, I'm not sure what the inquiry is actually. Do you know, Terence?
That's a good
Sorry,
question. I feel
sorry
like
to
I
put you
just
on the
read that
spot.
question out. For the person that added that question, perhaps you could add some insight. Were you referring to the inquiry into the deaths of several young people in Victoria, um, or were you talking about the national suicide prevention strategy? If maybe just clarify that in the Q&A for us, and I'll try to get back to it if there is time. Sorry, I just read that one out. I've come to the end of the
No, that's okay.
curated list that I had, and I'm now just going straight from the Q&A. This person says powerful data, implications and recommendations. Can you comment on the representativeness of the samples and how that impacts the generalization to each state and state-by-state comparisons?
Yeah, absolutely. So in terms of the representativeness, I guess if you're talking about queer-specific subgroups or queer-specific representation within each state and territory, for instance, there were roughly equal amounts of trans and gender diverse folks within each state and territory. comparatively, as well as cisgender sexual minority folks of a variety of sexual orientations, and also race and ethnicity were also relatively comparable across each state and territory as well. Yeah, so basically, in short, I think this is also why we're seeing relatively comparable results across state and territory, is that within each state and territory, the story is relatively the same as sort of the national pattern of results as well.
Excellent, thank you. Madly reading questions, unfortunately, way too many to answer, I think. Did your research identify strategies and factors that make a positive difference for people when accessing services or help seeking?
Yeah, that's a very good question.
Might be a bit granular.
Yeah, I think I don't think we have the data to really dig up that, unfortunately, but it's definitely something that we're hoping to do a little bit more in future, especially with new grants that sort of came through over the last couple of years, looking at healthcare access in particular, where we would have the opportunity to ask a bit more fine-grained approach, especially in terms of what strategies work and what strategies don't. It would be something that we're very interested in because it's very much the behavioral almost answer to going, okay, if we do this, then we could actually help more people or get more people coming into our service and various things like that. But yeah, it's definitely something that is needed. It's much needed.
I'm trying to remember if it was these reports or Rainbow Realities where there was a sort of discussion around whether people preferred going to a community-controlled organization or a mainstream service.
Yeah,
Was that something that played out in the state report and territory reports?
Yeah, so we definitely asked about that, and basically the result is that people mostly preferred queer inclusive services rather than either mainstream or having no preference or a queer specific service. So it could even be that even that ensuring that your healthcare clinicians and the people that work in your healthcare center are more inclusive in their practices could be enough to help as well. But then, of course, having queer specific services covers that as well. But I think it also just could be in terms of state and territories not having access to these queer specific services, which might be, for instance, in more metro regions rather than rural and remote regions, and a variety of other factors in there as well.
Thank you very much. The next question is from an anonymous person that says, have these reports and data been able to be used in advocacy for inclusion of variations in sex characteristics and gender identity in the ABS census and subsequent data sources? I didn't do some of that work myself, but the reports as they stood were launched at that time, and I know that LHA shared a lot of resources, as did other organisations, in proving worth in investigating, inclusion in the census much deeper. So I would say that they probably were, but as I didn't do that work myself, I'm hesitant to answer 100%. This question is about how can we raise the awareness of high levels of distress with our agender asexual community members, with their reporting numbers being so low. Many of our community members are underrepresented and have very little voice. There are a variety of intersections, and can we highlight the rates of distress and intersectionality and pinpoint minority distress for the smaller groups? And I guess not just that particular subsection, but Jordan, perhaps to widen the question a little, like how are we working with those smaller subsections that perhaps are a little underrepresented in those particular studies that have been and gone?
Yeah, absolutely. Look, I know, especially from the data that we have, ACE folks are definitely underrepresented. And there are, I guess, sort of efforts on the way to try and understand A, why that might be, and B, in terms of how we could actually better collect data from these more underrepresented communities in the data that we have. So definitely all of these questions are coming up in terms of how we might progress forward with the new surveys that we will be launching, in terms of how to better and more accurately represent the voices of these more marginalized communities to understand yeah, just to understand what these rates are and things like that. So yeah, it's definitely, I understand, like I feel you. I understand the question, and I feel like it's definitely something that needs improving.
Thank you. Thank you to the person who asked about um, the National Suicide Prevention Strategy. It was the advice on the National Suicide Prevention Strategy consultation draft. And now I just need to go back and find what the original question was so I can respond to that.
Any observations about the recent strategy draft?
Right. Yeah, so LHA responded to that, as did many of LHA's member organizations. And we highlighted some of the shortcomings. We strongly advocated, along with other suicide prevention organisations and the peak body, Suicide Prevention Australia, for more visibility and inclusion around LGBTQ plus communities, but also the I as well, recognizing that the data doesn't necessarily exist to back that up, but still very much advocating for those things in that strategy. And we partner with Switchboard Victoria on the Changing the Landscape project. And if people feel passionate about this particular area, I'd encourage you to go check out the website the landscape.org.au, and you can have a read of the statement that has been prepared that you can read and agree to. If you work in an organization, you can also complete some steps to validating that support as well. Look, there's so much more we could talk about with these topics, and they're an amazing set of questions. I'm so conscious that we didn't get to every question, but unfortunately we probably are out of time for this afternoon. Jordan, thank you so much for your time and expertise and generosity in sharing all of that, and particularly also filling in for Nat as well. It was great to have you. Thank you to my colleague Liz, who's been slaving away in the background throughout this session, answering questions and keeping us live and going. I just want to remind you that there is a brief survey, a feedback survey at SurveyMonkey. I might ask that Liz post that in the comment rather than me read that out to you, but it's a SurveyMonkey. Don't forget there's also support available if needed. We have talked about some heavy stuff this afternoon, and we know that the world is a bit of a tough place at the moment for all of us, and for some even more than others. And remember that Q Life is there to support as well. Thank you everyone for joining us and your interaction and enthusiasm this afternoon. We wish you a very good day. Bye for now.
Thank you.